competition, especially to have young people up here telling the best of their work. And so we have quite a lineup, so we need to stick to time, and we're going to be very strict sticking to time. We also have a slight change in the order. Unfortunately, Pichoy was not able to come to Cairo. And therefore, Emmanuel Lansac is going to present the first abstract. It's abstract number 4, actually, but you have to present in a different hall a little bit later on. So I'd like to welcome you to the floor, and it's a very long title. Perhaps you can explain us more. Thanks, Emmanuel.
Thank you. Thank you very much, and thank you for accommodating. I'm indeed replacing Pichoy Daniel, who did this work on lifetime management of aortic insufficiency. Start with aortic valve repair, because the idea, as you've listened today, is to see whether repair is doing better than replacement. And this is a work from the Valve Research Network, from the Heart Valve Society, on the multicentric comparative outcomes of repair versus biological valves. Oop. How does it move? Oh, maybe I'll do that. Yes. So 80% of the valves are potentially repairable, and in the EUROD survey, only 21% are actually repaired, and that's even lower in the US. And we know that aortic valve replacement, and this has been documented on several original articles, showing that there is a 30% death rate after a bioprosthetic valve at 15 years, and 26% for mechanical valve in the base of our thinking to establish this trial, this study. So the study design was on the Heart Valve Society database, and we include a biological valve replacement versus aortic valve repair with an aneurysm or without aneurysms. And the idea was to present long-term survival, major adverse valve-related events, and valve-related reoperation. So the baseline characteristics of the patients were the patients were matched after both groups. In both groups, there were more than 6,700 patients in the repair groups, and 545 in the biological replacement group. And we matched the two patients with a mean age of 65%. There were 36% isolated aortic valve repair, 28% tubular aorta and valve repair, and 36% valve-sparing root replacement with repair. The overall characteristics of the patients were as shown on that slide. There were a fair number of biological bicuspid valves, around 1/3 of the cases in both repair group and replacement group. And basically, additional procedures were similar in both groups. Outcomes before matching show a difference in terms of survival at 7.5 years, with 93% survival in the repair group versus 71% in the replacement group. After propensity matching, this difference was maintained, with 85% survival at 7.5 years versus 73% in the biological replacement group. In terms of major adverse valve-related events, we had a similar significant trend, with 86% freedom from major adverse valve-related events in the repair group versus 67% in the biological aortic valve replacement group. And after matching, This was also maintained with 95% freedom from major adverse valve-related events in the repair group versus 72% in the biological aortic valve replacement group. Regarding other events, we see that this is the summarized table, that survival was significantly in favor of aortic valve repair already at 7 years. Major adverse valve-related events significant. The late reinterventions were not significantly increased after aortic valve repair particularly, and there was also there was a difference in terms of endocarditis, where there was 0.6% endocarditis in the repair group versus 3.7% in the replacement group. So this is also very important things. In terms of moderate valve dysfunction, there was a difference in favor of biological aortic valve replacement, which was a little higher in the repair group, mostly due to AI grade 2 in the repair group, and severe valve dysfunctions was more present in the replacement group, 10% versus 6% in the repair group. And what is very important, and this has been already documented on a shorter series, but endocarditis is more present in valve replacement group compared to repair group. And for structural valve deterioration, for the severe structural valve deterioration as well, these are the curve where they are more present in the biological replacement group versus repair group. For the moderate structural valve deterioration, as I said, they were mostly due to AI grade 2 in the repair group, and for the stenotic valve, they were more present in the biological aortic valve replacement group. So these are the slides that Pishoy made. So he put some slides on the cost. I'm not really aware of that, but just want to make the link with the mechanical comparison with the CAVIAR trial that we already did, comparing repair versus mechanical valves, showing benefit in terms of survival and in terms of major adverse valve-related events. So what we already found for mechanical valves compared to repair, we also find it in the biological aortic valve replacement groups. So in other words, we have a better long-term survival and lower valve-related deaths and reduction of major adverse valve-related events, infective endocarditis, and severe valve dysfunction compared to aortic valve repair with a biological substitute. This will help to increase the place of aortic valve repair and bring it, raise the level of evidence to advocate aortic valve repair compared to replacement, particularly in young adults, and we hope that this will help to raise the level of evidence in the guidelines, particularly the European guidelines that are coming up soon. Thank you very much for your attention.
Thank you very much, Emmanuel. If there's any people in the audience who have questions, please come up to the microphone and state your name and affiliation and ask your question.
Oh, yes. Can you put the microphone? Can you put the microphone in the front?
I don't know if you, it's better? Hi, Emmanuel. My name is Bardi Arabkani, a cardiothoracic surgeon from Rotterdam. Thank you very much for this great presentation, and of course, if presenting on behalf of somebody else, really hard. I have a question and a comment. The question is that some people may say that there is maybe a selection in this database, but I know that there is in the database a variable which is intention to repair. I think that almost half of the patients had this. Have you looked at those patients as well? Because those are the patients that who maybe who had a replacement in the group and who were deemed to have a repair at the first place. What I want to say is this is pretty comparable patients if you even take into account that point.
Yeah, no, that's the point. That's the difficulty. Of course, they're biased into that. Just looking at the numbers, we have way more repairs than bio-valve replacements. I think the propensity matching helps in that regards, not into identifying the repairability, because that depends on the surgeons and on the group, of course. But in terms of matching the patients, making them comparable. That's a real question for pushing towards global evaluation, having exhaustive inclusion of all consecutive patients to have more patients. But this is.
And another thing is regarding the endocarditis. I think that this may be also a real major issue, because when we follow patients for many years, we know that the endocarditis is associated with high mortality. And what we know from mitral valve surgery, you know, in the beginning that valves were replaced, and now it's the new gold standard that you should repair the valve as long as it is repairable. I think that should be also the case for aortic valves, and no matter the age, of course, maybe not in an 80-year-old with a severe impaired left ventricular function, but taking into account the valve-related events in the future should also be a major issue as far as I'm concerned, because these patients may develop an endocarditis or a valve-related event in the future, which is associated with higher mortality and morbidity. So
I can't agree more. I can't agree more. And this is when listening to the talks where we go straight into SAVR versus TAVR versus TAVR versus SAVR, which one valve in valve and so on. The first questions, I agree with you, is repair, and how can we raise the rate of repair from currently 15 to 20% to 80%. This is key, and thanks for leading the Scientific Valve Research Network committee.
Thank
for
you.
that.
Time for one brief question. Amin.
Hi, Amin Mazin from University of Toronto. Very brief and somewhat basic question. You often mention this 80% of valves are repairable. Could you comment on what are the 20% that are not repairable? So which valves would you simply say these are not valves where repair should be attempted at all?
That's a very good question. The 80%, when we look at in intention to treat in my center with all the surgeons and all the patients, we looked at 80% were repaired. Actually, when we in my practice right now, looking at dystrophic AI without any stenotic components, I think it's more than this, but that's the lower version. It's like for the dystrophic mitrals. They are almost 100% repairable if they are managed by a team that knows how to do repair mitral valves, and this is similar for the dystrophic. I'm not talking about restrictive AI with rheumatic disease, which can be repaired in certain cases, but really not what we're talking about, which is mostly the dystrophic ones. So I think this is the lower version, but we're starting for 15%. Reaching 80% is already a good goal.
Thank you. Thank you for the nice presentation
and
discussion.
Thank you very much, and thank you for accommodating.
Now we will return to our normal schedule, and we will have the second presentation by Dr. Marie-Ange Fleury, comparison of long-term outcomes of the Ross procedure versus aortic valve replacement with mechanical or bioprosthetic valves.
Hi
Hi, everyone. Thank you very much to the organizing committee for allowing me to present results today. So I'm a PhD candidate in biomedical sciences, and today I'm pleased to report our center's experience in long-term outcomes of the ROS procedure. So as many of you know, choosing the ideal valve substitutes when it comes to young and middle-aged patients remains elusive and complicated, as we spoke about this morning. The choice has to be carefully considered with the long-term outcomes, quality of life, as well as patient preference. The ROS procedure is an alternative that doesn't use exogenous valve tissue, so it can, in fact, be less potential for valve degradation. So the ROS procedure is only performed in high-volume centers. We are one of those centers, so at the Quebec Heart and Lung Institute. For this study, we included all patients that underwent isolated AVR, and we did 2 separate propensity score matches with both mechanical AVR and biological AVR. Our primary endpoints were mortality, and secondary endpoint were reintervention and composite endpoint of reintervention and mortality. So here's the study flowchart. Following the propensity score matching, we were able to match 285 ROS patients with 285 mechanical AVRs and 191 ROS patients with 191 biological AVRs. Here are the population characteristics for the first match with mechanical AVR. We can see that the patient mean age was around 46 years old, mostly male patients, with the main comorbidities being dyslipidemia and hypertension. After matching, there were no statistical differences between both populations. For the second match with biological AVR, we have slightly older patients with a mean age of around 52 years old. Same things were present, so male, mostly with hypertension and dyslipidemia. Here are the important results. So here are the survival analysis, first with the biological AVR. We can see no statistical difference with mortality on its own at 30 years. When it comes to reintervention, however, at the 10 to 15 year mark, there's a sharp increase in reintervention for biological AVR. And for the composite endpoint, we see the same thing with statistically different outcomes. So higher incidence of reintervention for biological AVR and composite endpoint. As for mechanical AVR now, we can see that there's no statistical differences in all our endpoints, so there doesn't seem to be any effect of the mechanical aortic valve. However, those patients have to be anticoagulated, so that has to be taken into account for the quality of life perspective. We have the short-term complications here, so we can see that complications are fairly low rates at our institution, and there were no statistical differences between all groups when it came to the procedure type. So in conclusion, at our experience center, there's similar long-term survival for both mechanical and biological AVR, with lower rates of reintervention for the ROS procedure compared to biological AVR, but similar to mechanical valves. So the ROS procedure provides excellent long-term outcomes for patients that require AVR, and it's an excellent option for lifetime management of the disease. We are right now looking into the incidence of major bleeding and stroke to compare if patients with mechanical valves have significantly more risk of those. So thank you very much.
Thank you, Dr. Fleury. Is there any questions from the floor?
I just have you have a question? Go ahead, you are first.
So 2 questions actually. Number 1 is for the comparison with mechanical valves. Did you look at cardiac-related mortality as opposed to all-cause mortality? That's number 1. Number 2 is with respect to your follow-up, which is 30 years. How complete is the follow-up, and how did you obtain the follow-up?
Yeah, thank you for those great questions. So first question was regarding the
cardiac or valve-related mortality.
We have the data for ROS patients, but unfortunately for the mechanical and biological groups, we don't have cardiovascular death for all of them. So therefore, we didn't use that as an outcome in this study, but it would be preferable to have a cardiovascular death. As for the follow-up duration, for all ROS patients, they're followed up at our specific ROS clinic, so there's a 100% follow-up for those patients. For patients with biological or mechanical, it's a bit different because patients come sometimes from far away, but it's pretty complete, I would say.
Thank you very much. Excellent presentation. I'm Fabio De Robertis from Harefield Hospital. You already answered the question about the completeness of follow-up. So can you give us a percentage, roughly, for the completeness of follow-up in the prosthetic population? And the second question is, have you got any information about endocarditis, incident of endocarditis on prosthetic?
Great question, thank you. The percentage, I don't have it in mind right now, the percentage of follow-up with prosthetic patients. Endocarditis was very, very low in this cohort. I think there was 2 or 3 patients that ended up with endocarditis in the total number of patients, so very low.
Thank you.
Thank you.
The boss.
Let me just sneak one in just quickly, because the data is not quite consistent with what's been published recently. I'm not saying it's not correct, but I'm just saying it's what you observe. The mortality rate in the ROS cohort in the long term was higher than any other published series of long term in high volume centers, et cetera. Any explanation for that with the 100% completeness of, were they all committing suicides? Were there more accidents than usual?
Yeah.
What explains that?
Yeah, thank you for your question. I was expecting it since our results slightly vary from what has been published. It's hard to say. We have 100% follow-up, so all patients are included. So car accidents, suicides, they're all included in the study. Also, we're looking at 1990 for the start of the procedure. So the ROS procedure of 1990 is going to be less worse than the procedure that's completed today. So hopefully with time we'll see a better outcome for the ROS procedure at our institution, but unfortunately that's what we report today.
Okay, thank you very much. We have to move, and the next paper is entitled Sex Differences in Aortic Valve Inflammation and Remodeling in Chronic Severe Aortic Regurgitation. It's going to be presented by Mathieu Garaycoechea from Pamplona, Spain. Thank you.
Thank you so much. I'm pleased to introduce you our work about sex differences in aortic regurgitation. As you may know, aortic regurgitation is the 3rd most common non-rheumatic form of heart valve disease, and its prevalence is established around 1.6% in the general Western population over 65 years old. It's more commonly diagnosed in men, although women have worse survival rates and outcomes. To explore the sex differences in this disease, we have explored the clinical characteristics of a cohort of 144 patients, and of them, of note, 1/3 were women. Laboratory approaches we performed. On one hand, we have explored aortic valve histology and made molecular analysis on them. On the other hand, we have extracted the valve interstitial cells, VICs from now on, to perform in vitro assays. The general clinical characteristics of our cohort did not differ between sexes, except of the weight and height, as expected, but more interesting results were found in the indexed aortic dimensions measured by echocardiography. As you can see, women had larger annulus, sinuses of Valsalva, sinotubular junction, and ascending aorta sizes. Moreover, we've measured by CT the aortic valve thickness, finding that aortic valve from men were slightly thicker and statistically significantly thicker. Coming up with the laboratory results, we see that hematoxylineosine stainings showed that men aortic valve had more cell presence. And moreover, we used a cytokine array measuring a battery of pro-inflammatory cytokines from the protein extracts of the aortic valves, finding that men aortic valves were predominantly more inflamed. To further validate these results, immunohistochemistry was performed, finding that men aortic valves had more macrophage infiltrates seen by the CD markers, along with having more cytokine overall accumulation. as you can see by the brown markers. Along with that, the protein extracts were measured by ELISA techniques in the laboratory, finding that among other many cytokines, CCL2 and IL-6, pro-inflammatory master cytokines, were again more present in men aortic valves. Regarding fibrosis, we have also measured and quantified the area occupied by fibrotic tissue, and we found that men leaflets were more or had more fibrous percentage area. We further investigate this kind of fibrosis and found that women fibrosis were, fibrotic area was composed by thinner fibers, while men fibrosis area was composed by thicker fibers, seen by under polarized light. This could suggest us that men leaflets could be stiffer. Next, we analyzed the transcriptome of 3 women and 3 men extracted valve interstitial cells, and we found that women VICs had increased the lipidic metabolism compared to men VICs. On the other hand, the men VICs had increased the TGF-beta and TNF-alpha pro-fibrotic and pro-inflammatory processes, respectively, along with having higher proliferation rates. Complementarily, Olink analysis of these cell supernatants were seen that men VICs had a higher pro-inflammatory secretion compared to women VICs. However, we wanted to see if the TGF-beta addition to VICs culture, which is a master cytokine involved in heart valve disease development, could exert differential effects in men and women VICs. And we found that IL-6 and CCL2 levels were only increased in men VICs. On the same way, we have explored the extracellular matrix component secretion in both men and women VICs, finding that the TGF-beta secretion increased the TGF-beta stimuli increased the secretion of procollagen 1 in both sexes, but only increased decorin and aggrecan levels in women. To sum up, we conclude that aortic valves from men have more fibrosis than women, that aortic valves from men have more inflammation also, and that in conjunction with this, VICs from men have a more pro-fibrotic and pro-inflammatory profile. On the other hand, women VICs have a higher lipidic metabolism profile and proteoglycan secretion under TGF-beta stimulus. Thank you for your attention.
Thank you very much. I hope you are not going to say Trump is going to be happy to know there are differences between the two of them.
I had a question regarding the presence of bicuspid valves between the two groups and potential phenotypes of aortic aneurysm, since bicuspidity may be associated with aortopathy.
Yes, that's that's a really good question we have looked at, because bicuspid aortic valves are more frequent in men. We did not get the statistical significance, but yes, we have explored our data, and as you can see, the bicuspid aortic valves are more inflamed, but this more inflammation was not blunted by the morphology of the valve. As you can see, these 2 cytokine levels were significantly higher in men. If you compare tricuspid men and women aortic valves, you still have that higher inflammation in men. And same happens with fibrotic markers.
Okay, and are you going to introduce more tariffs on bicuspid valves? Okay, thank you very much.
Thank you.
Thank you. Any other question or comment? Please.
Hi.
I have a question for you about your results. So you're showing that men tend to have more fibrosis than females. That's the opposite of what's usually reported in literature with calcium scoring and all of that. Do you have any explanation for that?
Not a really actual explanation, but it's true that in aortic stenosis it has been described that women have more fibrosis while men tend to have more calcification accumulation. This data maybe suggests that aortic regurgitation is a different entity from aortic stenosis, perhaps. And yeah, of note, we do not see calcific deposits in our heart valves overall. So yeah, I would say so.
Please.
Veronica Misaidova, Centro Cardiologico Monzino, Milano. I have only one small question. Did you analyze the calcium presence by CT in these patients? It can be, I understand that it's insufficient patients, but maybe that even little percent of calcium was analyzed on these patients.
I'm sorry, I'm not...
Aortic valve calcification by CT scan. Did you measure?
Well, I have to say that I'm a basic scientist, and this data was analyzed by my doctor colleagues, so maybe we can discuss later looking for the data. Yeah.
Thank you.
Thank you.
Hi, Arsene Zibernik, Oslo University Hospital. So I do wonder, the single dots that you show in the graphs, is it like a single donor or is it technical replicates?
These single dots are single donors of the full cohort, but the single dots from the in vitro assays are in vitro replicates by, I think in these experiments were 4 donor VICs. So in the general graphs of about aortic valve tissue, it's a donor, while here we use like 3-4 donors per sex.
Got it. Thanks.
Last. Thank you.
It's a very interesting topic. It's Kang Jiawu from China. Quite regarding to the different profile, including the fermentation and the TGF-beta signaling, the turn on. Did you see those kind of the inflammation profiles and the TGF-beta signaling is associated with the calcification or any kind of pathogenesis? Thank you.
Okay, thank you. As I have said before, we do not find differences in the calcification processes and calcific markers of, for example, BMPs, osteocalcin, and these markers between both sexes, because when we look at the heart valves from aortic regurgitation, we do not see calcification presence either.
Thank you so much. That was a good discussion. I'm sorry for the noise in the back. Well, let's move on. The next speaker is Amin Mazin from the University of Toronto, and he's going to give us a word of caution based on North American trends in the utilization and outcomes of the Ross procedure.
That's not the right one. I have another one. Maybe it's this one. Yeah, thank you. Okay, thank you very much. On behalf of my co-authors, I want to thank the scientific committee for the opportunity to present our work. We have no relevant disclosures. Since its inception in the 1960s, enthusiasm for the Ross procedure has waxed and waned. And beginning in the late 1990s, there was a gradual decrease in the use of this operation in adults, such that by 2010, the Ross procedure accounted for less than 0.1% of all AVRs performed across the STS database. There are several factors that explain this abandonment of the operation, one of them being the perceived higher operative risk of the Ross procedure compared with that of a straightforward AVR. And this concern was substantiated by Brett Rees and colleagues in an analysis of the STS adult cardiac surgery database spanning the years 1994 to 2010. During this period, the Ross procedure was associated with an operative mortality of 2.7%, which was threefold that of conventional AVR. It is important to note that among the 231 centers included in this study, the median annual number of ROS procedures per center was less than 1, and only 6 centers performed 5 or more ROS procedures per year. And the authors did not investigate the relationship between volumes and outcomes in this study. Nonetheless, they concluded that increased short-term morbidity and mortality of the ROS procedure in adults does not justify its use as a viable alternative to isolated AVR. Despite this, in recent years, there has been a resurgence of interest in the ROS procedure owing to the publication of several studies demonstrating excellent long-term results in the hands of expert surgeons and superior long-term outcomes compared with conventional AVR. And so against this backdrop, we sought to document the contemporary trends in utilizations of the ROS procedure in adults and to examine the relationship between surgical volume and outcomes. To do this, we queried the STS adult cardiac surgery database for all ROS procedures performed between 2008 and 2023, and we identified 2,268 ROS procedures performed across 194 centers. This graph shows the distribution of cases among centers, and a few salient points are worth noting. The total number of ROS procedures per center over the 16-year study period ranged from 1 to 506. 44% of centers reported only 1 ROS procedure for the entire 16-year study period. The median number of ROS procedures per center was 2, and the top 10 centers performed 53% of all ROS procedures in this cohort. With respect to baseline characteristics, median age was 43, 2/3 of patients were male, and this was a predominantly Caucasian cohort. Patients had relatively few comorbidities, and the majority of cases were performed electively, 17% redos, and the overall surgical risk was low. This figure illustrates trends in the annual number of ROS procedures. This number reached a nadir of 63 procedures in 2017, followed by a steady increase to 531 procedures by 2023. When expressed as a percentage of all isolated AVRs performed in patients 60 years of age or less, ROS procedures accounted for only 0.9% of cases in 2016, but subsequently rose, reaching 7.2% by 2023. With respect to operative mortality, first looking at the STS predicted risk of mortality for the entire cohort, it remained relatively stable at approximately 1% throughout the study period. In contrast, the observed mortality risk decreased significantly from 2.8% in 2008 to a nadir of 0.9% in 2020, before increasing again to 1.9% in 2023. Now, I mentioned a few slides ago that the top 10 centers performed 50% of the ROS procedures in this cohort. If you look at those centers specifically in green compared to the rest of the cohort, you can see that the recent uptick in mortality is entirely driven by the lower volume centers and is not observed in the higher volume centers, highlighting the volume outcome relationship. This graph shows the mortality per era. And for each of these eras, centers were categorized according to their ROS volumes. Centers were considered low volume if they performed 10 or fewer ROS procedures over the era, intermediate volume if they performed 11 to 50, and high volume if they performed more than 50. And mortality rates were consistently higher in low volume centers and lower in high volume centers, and this was seen across all of the eras. When considering ROS volumes per year, centers that performed only 1 or 2 ROS procedures on any given year had a substantially higher risk of in-hospital mortality than centers that performed more than 10. When adjusting for baseline differences, the mortality rate associated with the ROS procedure was 4.5 times higher when performed in a center that only did 1 or 2 that year versus a center that did more than 10. And these observations were consistent when considering individual surgeon volumes rather than center volumes. These findings have to be interpreted in light of certain limitations. This was an observational retrospective study. We don't report on long-term outcomes. And we used the STS database, which was a good resource, but also has some potential biases, including the self-reporting nature of the data, the potential for incomplete reporting, and the potential for misclassification bias. These limitations notwithstanding, we have shown that the utilization of the ROS procedure is increasing in North America. Risk of mortality reached a nadir in 2020 with a slight increase in recent years. The majority of centers still report low volumes, and there is a clear inverse relationship between surgical volumes and in-hospital outcomes. We conclude that when performed in low center volumes, in low volume institutions or by low volume Ross surgeons, the operative mortality of the Ross procedure is unacceptably high, and that this operation should be performed exclusively in comprehensive valve centers of excellence that can sustain high volume of Ross procedures. Thank you for your attention.
Thank you. Thank you.
Thank you very much.
Is there any questions from the floor, please?
Hey, Amin, great job. Jordan Bloom from Mass General. I applaud everything you've done for your Ross research, and this is incredible findings, and we all are anticipating them being published. So if you believe in the Ross Renaissance, how does a low-volume program or a low-volume surgeon get to become a center of excellence? There are a lot of people that want to do Ross. I mean, these data clearly show you shouldn't be doing them if you're doing less than about one a month, which I think we would all agree with. But how can one become a center of excellence?
Yeah, I'll give you sort of the highlights. I would also, I'm sure you've seen it, but I would direct you to the editorial that was published in JACC by our president about centers of excellence and what constitutes a center of excellence. But essentially, first of all, you need to have sufficient volume of cases. You have to have good aortic root volumes as well. And then the other thing you need is a commitment to the technique, a commitment to analyzing your outcomes, patient selection. You have to have proper imaging. You have to have cardiologists that are on board as well. You need to have ideally surgical partners also that are on board. So it really takes a village, but I think first and foremost it starts with the understanding that it's not a minor undertaking and that you cannot do this sort of sporadically because it's the new kid on the block is the popular thing to do these days. You really have to be committed to the principles of the operation as well as the things that promote its long-term success.
Thank you.
Yeah, I have a brief question. The little increase in more recent years, can it be due to the fact that new centers are starting programs and that there is a phase where you still need to get everything working? Have you looked into that?
We have. We've sort of dissected the data, but so you're right that some of those were new centers, but not exclusively. And the other important thing is that a lot of these new centers perform only one operation per year in that given year. So centers that have taken up the operation and have maintained high volumes, even if it's only for the last 3-4 years, did not see that uptick. So in the top 10 centers, some of those centers were new centers, but because they were high volume, there were no issues with operative mortality.
I think here the message you say that if there is an issues, don't blame the procedure, blame your training or the amount of procedure you do, but don't blame the technique itself.
Yeah, no, absolutely. I think we are strong proponents of the Ross, and I wouldn't want these findings to suggest otherwise. We believe in the operation, but we just want to avoid the mistakes of the past that have led to its abandonment in the 90s, where, because of technical details and issues inherent to how the operation was conducted, we kind of threw away the baby with the bathwater. We want this renaissance to be successful, and to do that, I think we have to learn from the mistakes of the past.
Okay, thank you.
Thank you.
Very nice presentation. Now we have to move on. We will go to Dr. Francesco Zittu from European Hospital Rome, Italy, presenting the next presentation, which is titled Outcomes of Isolated Aortic Valve Repair versus Valve Sparing Root Replacement in Patients with Primary Aortic Regurgitation.
Well, good morning, everyone, and thank you very much for the introduction and the opportunity to talk. Today I will be talking about a study we did titled When Diameter Defines Strategy, where we looked into outcomes of isolated aortic valve repair versus the valve-sparing root replacement in patients with primary aortic regurgitation. So, starting with some background, we know that both isolated valve repair and valve-sparing root replacement techniques have been widely used to treat patients with isolated aortic regurgitation. And based on guidelines, we know that the ascending aorta replacement is recommended when the diameter exceeds 45 millimeters at any level of the ascending aorta. However, there are still no clear guidelines, recommendations for patients with intermediate diameter, where in clinical practice there is still a huge debate around those patients and a fear for future intervention due to the potential enlargement of those diameters over time. So therefore, the aim of our study was to investigate the clinical outcomes and the aortic diameter progression after the isolated valve repair and the valve sparing root replacement in patients presenting with severe primary AR. And to do so, we included and identified all the patients that underwent aortic valve repair from the Heart Valve Society aortic valve databases. The exclusion criteria were the aortic dissection, active endocarditis, and the patients with a diameter above 50 millimeters, connective tissue disease. So after we identified those patients, those patients were then stratified based on their preoperative aortic diameters at any level of the ascending aorta, meaning the sinuses of Valsalva diameter, the syntubular junction, and the tubular ascending aorta diameter. Therefore, we had patients in group 1, the primary isolated aortic regurgitation with all the diameters below 40 millimeters. Then we identified patients with intermediate diameters. And then we had group 3 with a combined indication for ascending aorta replacement where the diameter were between 45 and 49 millimeters. And after this stratification, we looked and described outcomes after those two techniques, as we can see in the slide. So in the end, this study included 535 adults with roughly 10% of female, very low percentage in this study, with a median age of 45 years, of whom 61% of those patients had bicuspid aortic valve. Well, as we can see here on the table, patients in group 1 were the youngest, presenting with the highest number of female patients, while group 2 had the highest percentage of bicuspid aortic valves, but also patients presented with the largest aortic annulus diameter compared to the other groups. So when we look at the progression in diameters, we can see here in group 1, patients undergoing isolated valve repair, all aortic diameters at any level remain stable over time. Moreover, where comparing this technique with the aortic root replacement, we saw no differences in the sinus of Valsalva diameter progression over time, and that was in patients with all the diameter below 40 millimeters. But then, while looking at patients in the second group between 40 and 44 millimeters, on the contrary, while the aortic annulus remained stable over time for all techniques in the isolated valve repair, we then saw a progression of the sinuses of Valsalva diameter over time that was as well observed in the sinutubular junction diameter for those patients, although patients with double annuloplasty seemed to perform better in this cohort. But differently, the tubular ascending aorta remained stable over time compared to the other diameters. So then we described and compared the isolated valve repair technique with the valve sparing root replacement regarding the sinuses of Valsalva diameter evolution. And interestingly, we saw that the sinuses of Valsalva diameter increased in patients undergoing isolated valve repair and aortic root remodeling, but remained stable for those one undergoing root reimplantation. But when we look at the late reintervention, about the aortic valve, we also saw that we observed no differences in aortic reintervention in the first two groups, as we can see here in the slide on the left, but patients undergoing isolated valve repair experience a higher cumulative incidence of reintervention compared to the valve-sparing root replacement when the diameters were between 45 and 49, as we can see there on the right. So, to put these results in perspective, we observed that if nothing is dilated, no progression is observed. But on average, especially in the group with intermediate diameters, we observed a sinuses of Valsalva diameter progression that might be driven by an underlying orthopathy in these patients. But then the question remains, in case of the sections are between 40 and 44 millimeters, should we systematically replace the root, accepting the procedural risk in those patients? So, to conclude, when diameter defines strategy, both isolated valve repair and valve-sparing root replacement are effective treatments for primary aortic regurgitation when the aortic diameters are below 40 millimeters, providing stable aortic dimensions over time. For patients with intermediate diameters, either procedure may be used, but some concerns may arise for isolated valve repair and the aortic root remodeling due to their potential root enlargement over time. And as again recommended by guidelines, when the diameters are exceeding 45 millimeters, the valve-sparing root replacement should be preferred over the isolated valve repair. And with this, thank you very much for listening to this presentation.
Thank you. This was very nicely presented and very important data.
Thank you.
I think the two comments I have is for the 40 to 45 millimeter group patients, you say in isolated valve repair and remodeling, the sinuses expand.
Yes.
The sinuses don't expand with remodeling because it's all Dacron. Dacron tends to sometimes dilate over time. It increases by about 20% in diameter over the first couple of years, and then it stabilizes. So it's not, I would just separate native aortic dilatation from Dacron, just performance. But the important thing to remember is in these patients, if valve function is stable over time, there is an argument for leaving the sinuses intact because nothing is forever. These patients will come back for reoperation, as you showed. These patients are young, they're late 30s, early 40s. If they come back and they need a Ross procedure in the future, it is entirely two different operations when you have a valve-sparing root replacement that you need to do a Ross on versus native aortic root. So these are very, very important data that really inform how we should be approaching these patients. And the approach of valve-sparing for everybody regardless should be weighed against
Balanced,
what you're
yes.
showing here.
Thank you for your comments. Thank you very much.
Aki, thank you very much. So, thank you. Next paper is coming from San Francisco, and Naomi Lynn Haddock is going to hopefully present because I don't see her. She's not here. Naomi? Okay, you were. So the topic is biomechanical modeling of ascending thoracic aortic aneurysms, investigating the relationship between aortic regurgitation and wall stress. Thank you very much.
Good morning, everyone. Before I get started, I would like to say a big thank you to the organizers for letting us to present our work on biomechanical modeling of ascending thoracic aortic aneurysms, which investigates the relationship between the aortic regurgitation and aortic wall stress. So first of all, I would like to bring some relative concepts. Ascending thoracic aortic aneurysms are localized aortic dilations with a risk of rupture dissections, which are both life-threatening surgical emergencies with a very high mortality rate. Dissection is a biomechanical event that occurs when the wall stress is greater than wall strength. The biomechanical study of ascending thoracic aortic aneurysm seeks to quantify the physical forces of the aortic wall. So in this study, we used the finite element analysis FEA to study the aortic wall stresses in our ATAA patients based on the CT imaging. Aortic regurgitation is a condition in where there is a regurgitant flow through the aortic valve. It frequently coexists with ATAA, but the relationship with aortic geometry and the aortic wall stress patterns is still a mystery to us. Therefore, this brings us to the question about what is the relationship between aortic regurgitation and aortic wall stresses in ascending thoracic aortic aneurysm. So to decipher this question, we used the CT scans from 82 of our ATAA patients. Among them, 38 of them has their aortic regurgitation status, which in this case we use the binary status. And then we use them to generate the patient-specific FEA models at the physiological pressures. Then, after the FEA is done, 3D models of longitudinal and circumferential wall stresses model are made at the end of diastolic and end of systolic pressures. We could also see on the right, we converted the 3D pictures to the 2D ones, meanwhile maintaining its topology to give us a better visualization for evaluation. So our approaches use calculation of aortic geometry as diameter of rings along with the length of aorta. We also quantify the max and mean wall stresses at end of diastolic and end of systolic pressures. Because these are non-parametric data, we use the Mann-Whitney U-test for statistical purposes. So I would like to highlight 3 things in our ongoing study. So first of all, we do see a statistical significance in patients with AR status will have a higher average diameters at both the proximal root and the sinotubular junction. Secondly, we also found out they will have a higher peak longitudinal and circumferential stress at the end of the systole period. Lastly, it is also statistically significant that these patients will experience a more pronounced increase in both longitudinal and circumferential stresses during the systole period. So this is just to reiterate on our take-home message. So first, the specific geometry, which correlates with higher diameter at both proximal aortic root and the sinotubular junction. And also we found the higher peak longitudinal and circumferential stresses are related with patients with aortic regurgitation. And lastly, they will have a more drastic increase in wall stresses from the end of diastolic period to end of the systolic period. So we also would like to do the following in the future. So first, our patient number, I know that it is still pretty small, so we would like to perform a validation in a larger cohort among our patients. And second, we would like to see how distinct aortic geometry patterns will influence our wall stresses and associate these with patient outcomes such as acute aortic events. So lastly, we would like to evaluate the stress patterns across all 3 layers of the aortic tissue, intima, media, and adventitia. So today I'm actually presenting this on behalf of one of our medical students who is unable to be with us, which is Naomi Haddock. But also I would like to acknowledge everyone in our cardiac biomechanics laboratory who worked tirelessly on this project and all relatively things. Thank you so much. And
thank you very much. Any comments or questions? In fact, I was going to ask you one. You were explaining at the end you are doing, you are ongoing this about the 3 layers, in which one is going to be more important, the stress wall, the wall stress.
So this is a very interesting question because we also did some like tensile stretching with the. I don't think we did the media because it's too hard to separate those in between layers. Well, that's a more fancy question to ask the residents, but also from what I know is that it sounds like intima is more likely, is a little bit more prone to like uniaxial failure. But we have like relative studies about this.
Very good. Well, we are running short of time, so maybe we have to move. Thank you very much. Thank you.
So then I'd like to invite the next speaker on here, Mohiuddin Chema, I hope I pronounced that correctly, actually from Imperial College and the Magdi Yacoub Institute, who's going to talk about dysregulated expression of toe-like receptor valves. Oh, no, I have the wrong abstract. Or not? Yeah, no, that's right. He's going to talk about prosthesis-patient mismatch. I'm sorry. Following transcatheter aortic valve replacement is not associated with adverse 3-year outcomes.
Thank you. to the Society for the opportunity to present our data. We're going to talk about patient prosthesis mismatch after a TAVR procedure and midterm follow-up. I have no financial disclosures. The surgical literature obviously does significantly impact, the patient prosthesis mismatch does impact the survival as well as quality of life, but that data in TAVR is not available or remains controversial, but we're starting to see more and more on it. We assessed in-hospital and late outcomes in 2291 TAVR procedures that were successfully treated from a transfemoral approach with current generation TAVR valves since 2017. Patients were classified as having no, moderate, and severe PPM according to standard definitions adjusted for body mass index. Valve and valve cases were excluded from this data. To compensate for the baseline differences between the three PPM groups, a propensity match analysis was implemented using that inverse probability of treatment weighting methods, which is well described in the literature. The definition of PPM was adjusted for BMI of less than 30, indexed EOA of less than 0.65 was defined as severe, 0.66 to 0.85 was defined as moderate, and more than 0.85 was none. And for BMIs of over 30%, it was adjusted to a lower definition. Severe PPM was defined as indexed EOA of less than 0.55, and moderate as 0.56 to 0.7. This is the distribution and demographics of all the three categories. In essence, there was very little significant overall clinical differences between the three groups. The mean gradient was essentially equivalent, maybe slightly lower in the severe PPM group, and the peak velocities, LV ejection fraction, and aortic valve area was relatively same. In terms of coronary artery disease, most of these groups were well matched in terms of number of diseased vessels, as well as incidence of left main stenosis of more than 50%. In terms of the different types of valves used, for the SAPIEN 3 group was the most dominant group in the balloon expandable valves and the self-expanding valves. The Evolut Pro and FX were relatively new valves, but they were equally represented. The contrast used and fluoroscopy times were equivalent. And as far as the different groups, there was more representation of balloon expandable valves in the severe PPM group compared to patients who had none or moderate. If you can see on the severe PPM group, almost 85% of them were balloon expandable valves versus 14% that were self-expanded. But in the patient group that had no PPM, it was relatively equal distribution, almost 60% versus 40%. Most importantly, the all-cause mortality was not significant between the patients who had severe PPM versus moderate and none, and the stroke risk was also not significant. The permanent pacemaker risk was slightly lower with the severe PPM group, and the annular rupture was, the incidence was really low in terms of number of events, so you can't comment on the significance of that. But all the other parameters in terms of major vascular complications, bleeding risk, cardiac arrest, coronary obstruction, ventricular perforation or tamponade, or aortic valve insufficiency of more than a mile was insignificant between the three groups. This is the one-year outcome. The all-cause mortality was essentially the same between the three groups, despite having severe PPM, as was the hospital readmission rate. The late outcomes at mean follow-up of 32 months also showed no significant difference in all-cause mortality, aortic valve reintervention, incidence of stroke, MI, aortic valve endocarditis, as well as hospital readmission. This is the Kaplan-Meier survival curve. It shows that at the median follow-up of at least, midterm follow-up of at least 33 months, there was no significant difference in overall cumulative survival between the three groups. In conclusion, severe PPM patients had a higher incidence of annular rupture, a decreased need for a permanent pacemaker implantation, and a longer postoperative length of stay for their TAVR index admission. But there was no difference in one-year mortality or hospital readmission between severe or moderate or no PPM cohorts. At a midterm follow-up of 32 months, there was no increase in all-cause mortality, aortic valve reintervention, stroke, MI, aortic valve endocarditis, or hospital readmission in moderate and severe PPM group in this TAVR population. Thank you.
Thank you very much. Are there any questions from the floor?
So do you think that PPM does not matter in TAVR, or do you think that PPM does not matter in elderly patients? The reason I ask is because even in the surgical literature, when you look at the impact of PPM in patients who are above, say, 75 years of age, it's relatively minimal, whereas in younger patients, it's quite drastic. And as we're seeing, we saw earlier this morning, the indication for TAVR creep towards younger and younger patients, do you think that age will play a role in sort of modulating the impact of PPM?
I think we will know more as we follow these patients long term, but at midterm follow-up, there was no significant uptick in mortality or survival benefit. But again, these are relatively no number and a somewhat midterm follow-up. TAVR, as we all know, in general has lower gradients compared to surgical valves, even in patients with low annular dimensions. I don't know if that has anything to do with it and how we measure gradients. Is that different in TAVR patients versus surgical valves? It's a lot that we still don't know, but at least at midterm follow-up, there wasn't a signal of higher mortality in these patients. But I think, as we all know, I think looking at a large registry database like TVT registry to parse this out and a more long-term follow-up may be able to shed some light on it.
Sorry, I may have misread the slide, but was mortality almost 100% at 3 years in the before last slide that you showed?
So it was is equivalent in the three groups. The mortality, there was no difference in mortality or survival, but the mortality was about 23%, if I remember correctly from this slide. So, yeah, but it wasn't any significant difference between the groups that had no PPM versus severe PPM. So at least there wasn't any signal at that midterm follow-up.
Thank you for your nice presentation. Now we have to move up for the next presentation, which will be presented by Najma Latif from Imperial College, United Kingdom. And the title of the presentation is Dysregulated Expression of the Tool-like Receptors in Valve from Rheumatic Heart Disease Patients.
Hello, everyone. I'd like to show you some of our very preliminary data on the expression of toll-like receptors in valves from rheumatic heart disease patients. So, as a background, the toll-like receptors are a family of pattern recognition receptors, and they play a crucial role in the innate immune system. They detect pathogen-associated molecular patterns, which are abbreviated to PAMPs, such as bacterial components, or damage-associated molecular patterns, abbreviated as DAMPs, and these include oxidized lipids and heat shock proteins. You can have surface TLR and endosomal TLRs, and in this study we've looked at the surface TLRs, specifically TLR2 and 4, which bind to extracellular pathogens. So TLR activation promotes inflammation and calcification, and these have been shown to be highly expressed in human calcified aortic valves. The activation is through the NF-kappa B pathway, which increases inflammatory cytokines and also osteogenic differentiation of VIX. So the aims of this study was to analyze the expression of surface TLR2 and TLR4 in rheumatic heart disease patients and to assess their modulation. So we have control patients, rheumatic heart disease patients, and calcified patients. And we've used immunohistochemistry and flow cytometry. So this slide shows our data for the immunostaining of TLR2 expression. In control aortic valves, we see a population of interstitial cells predominantly along the ventricularis that express TLR2. In calcified valves, there is a very high abundance of valve interstitial cells that express TLR2, but in rheumatic heart disease patients, we were surprised to see hardly any expression of TLR2. Similarly, with the expression of TLR4, we see there is a population of cells along the ventricularis that express TLR4. Calcified valves have a very high level of expression in increased numbers, and rheumatic heart disease showed very little expression of TLR4. When you quantify this, you see that the rheumatic heart disease show a significantly reduced expression of TLR2 when you look at percentage area staining compared to controls as well as calcified aortic valves. And the same pattern was arising with TLR4 in that the rheumatic heart disease patients showed a significantly reduced level compared to controls and to calcified aortic valves. When you look at mitral valves, the pattern is similar. Rheumatic heart disease patients showed a significantly reduced expression of TLR2 and TLR4. When we try to analyze what causes this, we try to analyze what is causing this reduction of TLR2 and TLR4, and we've used human valve interstitial cells, and we're treating them with LPS, phosphate, or a combination. And this is preliminary data looking at myofibroblastic cells and fibroblastic cells because they can easily switch between the two phenotypes. A 7-day treatment does not change the percentage of cells expressing TLR4. However, a 7-day expression is showing a trend to reduce the TLR4 median expression. A 7-day treatment of the valve interstitial cells treated with the 3 compounds or jointly, LPS and phosphate, showed no difference in median expression of TLR4. This is looking at lipoteic acid, which is a gram-positive protein. And with this, we see no change in TLR2 expression, but a trend to decreasing TLR4 with increasing concentrations of lipoteic acid. So to summarize, we see a significant downregulation of TLR2 and TLR4 in rheumatic heart disease. And usually, in calcified valves, you see an upregulation, but this downregulation is observed when the immune system can be exhausted or suppressed or chronically stimulated. While this can prevent inflammation, it often results in increased susceptibility to infections and tumor progression. As moving forward, we're hoping to identify biological mediators, blood markers, which would result in this downregulation of TLR4 expression in our cohort of rheumatic heart disease patients. Thank you.
Thank you. Any questions from the floor, or we will move on? I think we will move.
Thank you very much. We have to move because we are running short of time once more. High-intensity statins are associated with increased aortic valve calcification in patients with severe stenosis. A very interesting topic, and it's Veronica, you're there, Miasodova, who is coming from Monzino, Milano, Italy. Thank you very much.
Thank you so much for your kind introduction. Good morning, everyone. No, it's not this one. I'm sorry, I didn't find my presentation. It's here. Okay. Can I use this one? Because I use this one. Okay. Well, thank you again for the kind presentation. It is well known that aortic valve stenosis is the most common aortic valve disorders and is associated with increased mortality and morbidity, but there is no pharmacological treatment for this disease, and the surgical and transcatheter aortic valve replacement is the unique approach used when the disease became severe. Aortic stenosis share many pathological mechanisms with atherosclerosis, and also the comorbidities such as dyslipidemia, hypertension, or diabetes are very similar between this disease. But the drugs taken for these comorbidities may influence the pathology. Indeed, statins have not only lipid-lowering properties, but also can modulate PCSK9 production. And also high concentration of PCSK9 plasma and tissue level was shown to be associated with increased calcification. Thus, the aim of our study was to investigate the dose-dependent effect of statins on aortic valve calcification in patients with a severe aortic valve stenosis. For this, we perform in vitro study the analysis of the effect of the statin on PCSK9 secretion and calcium accumulation in valve interstitial cells isolated from the stenotic aortic valve leaflet. And what we found that both atorvastatin and pravastatin induce PCSK9 secretion and calcium accumulation in dose-dependent manner, showing a nice correlation. Using genetic PCSK9 valve interstitial knockdown valve interstitial cells, which secrete significantly less PCSK9, statin failed to induce PCSK9 secretion and calcium accumulation. While blocking PCSK9 with neutralizing antibody, we saw a decrease of calcification under statin treatment. Well, our next step was to understand if statins may, intensity of statins may affect on aortic valve calcification volume in an imaging study. To this, we enrolled almost 300 patients who underwent echographic and CT evaluation before surgery. There was no difference between two groups, low-intensity statin group and high-intensity statin group in the clinical variables, and what we found that the patient taking high-intensity statin therapy have higher amount of calcium in aortic valve leaflet compared to patients who take low-intensity statin therapy or who don't take the statins. And almost 30% of our patients underwent multiple evaluation of CT and echographic evaluation, and we was able to analyze the effect of statin on aortic valve calcification progression. It was a well-balanced population. And here we find the same results, and applying the aortic valve calcification threshold cutoff of 200 to avoid the measurement errors, we saw that patients taking the high-intensity statin therapy avoid this cutoff compared to the patients with low-intensity statin therapy or non-therapy. And interestingly, there was no difference between all 3 groups in the classical echographic evaluation of aortic valve stenosis progression. Our last step was to understand the effect of intensity of statins on the hospitalization rate for aortic valve disease in a real-world scenario. 850,000 new statin users was included, and of this we excluded the younger patients who underwent aortic valve replacement, or patients who take the statin for less than 2 years. And in our final analysis, we include almost 80,000 low-intensity statin users and high-intensity statin users. This population was balanced for the sex, age, multi-comorbidity score, diabetes, but only hypertension was slightly higher in the patients taking high-intensity statins. And what we found, in 5 years of follow-up, patients taking high-intensity statin therapy shows an increase of incidence of hospitalization for aortic valve disease compared to the patients who take the low-intensity statin therapy. And it was true even after adjustment for hypertension. So I can conclude that high-intensity statin therapy associated with increased PCSK9 secretion and aortic valve calcification in vitro experiments and in CT imaging evaluation in patients with severe aortic stenosis. The real-world data support our findings by revealing the high incidence of hospitalization rate for aortic valve disease in the patients with high-intensity statin therapy. And this finding highlights the need for further investigation of relationship between statin therapy, aortic valve health, to identify the optimal lipid-lowering strategy in the management of the patients with aortic stenosis. I would like to thank all my collaborators and, of course, you for your attention.
Thank you very much.
Can I ask one short question, very short question?
Yeah, I was going to tell you.
Did you look at potential differences between men and women? And do you think there are?
I am very interested in this. Thank you for your question. For sure, we checked, but it was no difference between ladies and men in the calcium accumulation under the statin treatment, in the CT imaging, and I can say about the valve interstitial cells, we prepared analysis only in the male subjects. In our cohort study, also there we did not find difference between sexes.
Okay. Both with regard to characteristics and outcomes.
Yes.
Yeah? Okay. Thank you very much. Oh, I get it. Great. So we're wrapping up this session, and we invite again to the stage Amin Mazin from the University of Toronto, who will present a paper on 20-year outcomes following porcine versus bovine pericardial aortic valve replacement.
Thank you. Let me see if I can give you the short version of this talk so everybody can go for lunch. Thanks again to the scientific committee. So we know that over the last few decades, there's been a steady increase in the use of bioprosthetic valves at the expense of mechanical valves. This is true both in elderly patients and in younger patients. And this trend is often ascribed to the rise of TAVR, but as you can see from this slide, it really precedes the introduction of TAVR clinically. When speaking about bioprosthetic aortic valve replacement, the two most commonly used types are stented bovine pericardial versus stented porcine prostheses. And our center is kind of peculiar because we have fairly extensive and contemporaneous experience with both the Carpentier-Edwards bovine pericardial valve and the Medtronic Hancock II porcine valve. There have been a lot of observational studies that have suggested or shown that the pericardial valves tend to have better hemodynamic performance, but whether this translates into better long-term outcomes is not well established. And so the goal of this study was to compare the long-term outcomes of the bovine pericardial versus porcine bioprostheses using population-level administrative databases from our province. We included all patients who underwent first-time isolated surgical aortic valve replacement with a Hancock II or a Perimap Magna at the Toronto General Hospital from 1990 to 2014. We excluded non-Ontario residents, patients who had previous AVR, concomitant surgery, or a root replacement. The mean follow-up was 11 years. The primary outcome was all-cause mortality. The secondary outcome was aortic valve reintervention, and we used inverse probability treatment weighing to account for baseline differences between the groups. These are the patient baseline characteristics after matching. The number on the right is not a p-value, it's a standard difference, so anything less than 0.1 is considered well matched. And I'll go over this quickly, but as you can see here, two very well balanced cohorts in terms of demographics, morphometrics, and comorbidities. There were substantial differences, however, in terms of the use of aortic root enlargement, which was performed more commonly in the bovine pericardial group. Incidentally, the number of patients who received a prosthesis labeled size more than 25 or 25 or more was greater in the porcine group, but the predicted indexed effective orifice area was higher in the bovine pericardial group. And so basically all that tells you is that you can't compare the labeled sizes between different manufacturers. Operative data equivalent in terms of in-hospital outcomes. Operative mortality was the same, stroke was the same, and permanent pacemaker implantation was the same. All-cause mortality did not differ between the two groups. At 20 years, it was 73% in the bovine pericardial group and 74% in the porcine group. However, the rate of aortic valve reintervention was substantially different beginning in the second decade of follow-up and was higher in the pericardial group as opposed to the porcine group. We performed two pre-specified subgroup analyses, first looking at age, and so what you see here is the solid lines are young patients, age less than 65, whereas the dotted lines are patients age 65 and older than 65. And as you can see here, in both cases, the rate of reintervention was higher for the pericardial valves as opposed to porcine valves, so age did not influence this relationship. The second subgroup was looking at prosthesis size. So again, in the solid lines, you have the larger prostheses, and you can see that if you implant a large prosthesis with a label size 25 or higher, the pericardial valves have a higher rate of reintervention than the porcine valves. But if you implant a smaller valve, which is the dotted lines at the bottom, then this difference is no longer significant. So the conclusion from all of this is that there is equivalent long-term survival between stented porcine and bovine pericardial SAVR. There's a higher incidence of valve reintervention with bovine pericardial SAVR, both in patients less than 65 and in patients above 65. There is no difference in rates of reintervention when the implanted valve size is less than 25. And collectively, these data suggest that porcine bioprosthetic valves may be preferable to bovine pericardial valves if and only if a large prosthesis can be implanted. Thank you very much for your attention.
Well, thank you, and that was fast, but clear. So, are there any questions from the audience regarding this paper?
Thanks for this very nice presentation. I was wondering, wait a second. What do you do in your center where it's not possible to implant a large prosthesis for those patients? Do you switch?
No, so this is retrospective, and it hasn't informed our practice yet. There are some surgeons within our group that will favor a pericardial valve in a smaller annular size, but by and large, the choice of the prosthesis type is largely a matter of sort of surgeon preference.
Surgeon preference.
But based on these data, I would say that if you have a small aortic annulus and you don't think you can enlarge it, or that you don't want to enlarge it, then I think a pericardial valve is probably a better choice.
Okay. Thanks. Thank you.
So one very short question.
Very short. Is there any information on the failure modes of the two types?
Not in this specific study, but it's pretty well established that pericardial valves tend to stenose progressively, whereas porcine valves tend to fail more acutely with leaflet rupture, but we haven't looked at that specifically here.
No, I think we're going to get kicked out of this hallway pretty soon, so I would like to thank you all for, first and foremost, of course, the speakers, but also the people in the audience who've actively contributed to lively discussions, I think, and please go ahead, have lunch, and we'll see you again this afternoon. Thank you.